Welcome to MLE Masters. In today's session, we're diving into one of the most high-yield and foundational topics, cardiovascular embryology, a subject that comes up again and again on USMLE Step 1. Let's begin with the basics. The cardiovascular system is actually the first major organ system to start functioning in the embryo. It starts developing earliest, as early as the third week of gestation, even before many other organ systems begin to take shape. And that makes sense because a growing embryo needs efficient circulation to deliver nutrients and remove waste. The heart and major blood vessels originate from mesodermal tissue, specifically from the splanchnic mesoderm. Initially, blood islands form in the mesoderm, which later coalesce to form blood vessels and the primitive heart tube. As the heart tube forms and begins to beat, it undergoes a critical process called looping, which sets the stage for the basic layout of the adult heart. These early events, formation, fusion, and looping, are all tightly regulated, and even small disruptions can lead to major congenital defects. So this topic not only helps you understand physiology, but also connects directly to clinical pathology questions you'll see on Step 1. Now, let's break down the structure of the primitive heart tube. The heart begins as a simple straight tube, but this tube already has 5 major segments, each of which gives rise to specific structures in the adult heart. From top to bottom, the tube is made up of truncus arteriosus, bulbus cordis, primitive ventricle, primitive atrium, sinus venosus. Each segment has a predetermined fate, meaning it will develop into certain parts of the adult heart. The truncus arteriosus becomes the base of the great vessels, like the aorta and pulmonary artery. The bulbus cordis contributes to the right ventricle and parts of the outflow tracts. The primitive ventricle forms the left ventricle. The primitive atrium becomes the muscular parts of the atria. And the sinus venosus forms the smooth part of the right atrium, the coronary sinus, and part of the sinoatrial node. The heart tube then undergoes rightward looping, known as de-looping, which positions the chambers correctly. If this looping goes wrong, it can lead to L-looping, where the heart chambers are malpositioned, a common cause of congenitally corrected transposition of the great vessels. Now that we've introduced the heart tube segments, let's take a closer look at what they actually become in the fully developed heart. This is a hot favorite for USMLE Step 1. Let's go through each one. The truncus arteriosus forms the ascending aorta and the pulmonary trunk. These are the 2 major arteries leaving the heart. The bulbus cordis develops into the right ventricle, as well as the smooth outflow tracts for both the left and right ventricles. The primitive ventricle gives rise to the muscular portion of the left ventricle, the powerhouse chamber. The primitive atrium becomes the muscular parts of both atria and contributes to the trabeculated appearance we see inside. The sinus venosus, especially its right horn, forms the smooth part of the right atrium, including the coronary sinus, sinoatrial node, and part of the inferior vena cava region. On USMLE, you'll often get matching style questions or clinical correlates that test your memory on which segment becomes what. A useful memory tip is to just visualize the heart tube looping and stretching into chambers and vessels, and link them to their final adult derivatives. Also remember, if a structure looks smooth in the adult heart, it's likely derived from sinus venosus or bulbus cordis, while muscular parts are from the primitive ventricle and atrium. Let's move to septation, another very high-yield topic. This is how the heart divides into 4 chambers, and it's loaded with testable concepts. In the atria, septation begins with the septum primum, which grows downward toward the endocardial cushions. It leaves a gap called the foramen primum. Later, the septum secundum grows beside it and leaves a hole called the foramen oval, the classic fetal right-to-left shunt. In fetal life, this is normal and necessary. But postnatally, this foramen oval should close. If it doesn't, you get a patent foramen oval, a common cause of paradoxical embolism on exams. Next, ventricular septation starts with the muscular septum growing upward. Then, the membranous septum, derived from neural crest cells, closes the gap between the muscular septum and the outflow tract. Most ventricular septal defects, VSDs, occur in this membranous part. Watch out for USMLE questions linking Down syndrome with endocardial cushion defects, which affect both atrial and ventricular septation. Now let's move into outflow tract formation. Another USMLE favorite because so many congenital defects stem from this. The truncus arteriosus, that top portion of the heart tube, must be divided into the aorta and pulmonary trunk. This happens through the formation of conotruncal ridges, also called neural crest cell-derived aorticopulmonary septum. These ridges spiral as they grow, creating a twisted separation between the right and left outflow tracts. This spiral nature is critical. Without it, the aorta and pulmonary artery could end up attached to the wrong ventricles. If these ridges don't form or spiral properly, you get major congenital heart defects like transposition of the great vessels, where the aorta arises from the right ventricle and the pulmonary artery from the left ventricle. Tetralogy of Fallot, which includes 4 classic features: pulmonary stenosis, ventricular septal defect, overriding aorta, and right ventricular hypertrophy. Persistent truncus arteriosus, where there's only one common outflow tract instead of 2. On USMLE, if you see the phrase failure of neural crest migration or spiral septum defect, think of outflow tract anomalies immediately. Next up, we explore fetal circulation and the 3 vital shunts, another board favorite. During fetal life, oxygenation happens via the placenta, not the lungs, so the body has shunts to bypass underdeveloped organs, especially the lungs and liver. Let's go through them. Ductus venosus bypasses the liver, allowing oxygen-rich blood from the umbilical vein to enter the inferior vena cava. Foramen ovale allows blood to flow directly from the right atrium to the left atrium, bypassing the lungs. Ductus arteriosus connects the pulmonary artery to the aorta, again shunting blood away from the fetal lungs. After birth, these shunts close. Ductus venosus becomes the ligamentum venosum. Foramen ovale becomes the fossa ovalis. Ductus arteriosus becomes the ligamentum arteriosum, and this closure is prostaglandin sensitive. USMLE loves to ask what happens if these shunts remain patent, like patent ductus arteriosus, PDA, which presents with a machine-like murmur and is treated with indomethacin to close it. Also note, prostaglandins keep it open, while NSAIDs like indomethacin help close it. That's a great exam tip. Let's now bring everything together with some of the most important congenital cardiac anomalies. These are must-know pathologies directly tied to embryologic development and often tested on step 1. First up is atrial septal defect, or ASD. This results when the septum primum and septum secundum don't fuse properly or if the foramen ovale remains patent. Remember, patent foramen ovale can cause paradoxical embolism. Look for patients with stroke and no DVT source. This might be why. Next is ventricular septal defect, or VSD. This is actually the most common congenital heart defect. It usually occurs in the membranous portion of the interventricular septum, which, as we discussed, forms late and requires fusion of multiple structures, making it prone to defects. Then we have transposition of the great vessels. This occurs when the conotruncal septum fails to spiral, resulting in the aorta arising from the right ventricle and the pulmonary artery from the left. This causes parallel circulations, a condition incompatible with life unless a shunt like PDA or ASD is present. Tetralogy of Fallot, another high-yield condition, arises from anterior displacement of the infundibular septum. Remember the 4 features: pulmonary stenosis, VSD, overriding aorta, and right ventricular hypertrophy. This is often associated with cyanotic spells and boot-shaped heart on chest X-ray. Persistent truncus arteriosus results from failure of conotruncal septum formation, leading to a single arterial trunk, mixing oxygenated and deoxygenated blood. It's another classic result of neural crest migration failure. Lastly, Ebstein anomaly, a rare but high-yield condition where the tricuspid valve is displaced downward into the right ventricle, often linked to maternal lithium exposure during pregnancy. It causes atrialization of the right ventricle and is associated with arrhythmias. Keep all of these in your memory bank. Not only are they common on exams, but they help you understand how early embryologic steps shape critical clinical outcomes. And that wraps up our high-yield review on cardiovascular embryology. You've just learned some of the most frequently tested concepts, from heart tube formation, segment derivatives, and septation, to outflow tract development, fetal shunts, and congenital anomalies. If you master this topic, you'll not only breeze through related Step 1 questions, but also build a solid foundation for clinical medicine. Make sure to review the clinical correlates we discussed. Those are where Step 1 loves to test you. If you found this helpful, don't forget to like, share, and subscribe to MLE Masters, your one-stop platform for high-yield USMLE content delivered in a focused, easy-to-grasp format. Keep watching, stay consistent, and let's keep crushing Step 1, one topic at a time.